Welcome to another edition of Academic Fiesta from IMA Haryana. Today, we will discuss about the dementia. With our over engagement in social media and changing socio-economic condition, there is a steep rise in memory-related issues. Pre-senile dementia is increasing, and senile dementia, along with vascular dementia, is also on rise due to better life expectancy. So, do we have anything to prevent this serious disease which impacts our quality of life? So, we have a wonderful speaker with us today, Dr. Manish Mahajan, who was a senior consultant neurologist at the Metal Clinic Gurgaon. He is former associate chief of neurology and head neuroimmunology at Artemis Hospital Gurugram. He received many awards, including Bronze Medal in Pharmacology and Best Resident Award from Sir Gangaram Hospital. He is life member of Indian Academy of Neurology, American Academy of Neurology, and has written many chapters and articles in books and peer-reviewed journals. So, welcome, Dr. Manish Mahajan, for today's talk, and hope we will remember everything from his talk, and it will be a good learning for us. Dr. Manish Mahajan, please.
Thank you, sir, for the kind introduction. And first of all, at the outset, I would like to thank IMA Haryana for giving me this wonderful opportunity to talk among my senior colleagues and peer. It's a real privilege. And without further ado, I would like to share my slides. Just, sir, confirm whether they are visible to the audience.
Yeah, they are visible.
Okay, sir. The responsibility which was delegated to me was to talk about the preventable aspects of pre-senile, senile, and vascular dementia. And the very two important aspects of dementia I would like to highlight, and it would be an understatement. And this august audience is already aware of this important fact that age is the strongest known risk factor for any type of cognitive decline. But what is most important is to understand, and that has to percolate in the public at large. And I think we all have a social responsibility to disseminate this information, is that dementia is not a natural or inevitable consequence of aging. So if this is something which is a big myth among the people who approach us and complain of either subjective or their caregivers give us the information that they are having a particular or a progressive type of cognitive decline. So over this talk, I would be glad to discuss the global, and we will be discussing the global and the local burden of dementia. I'll define the pre-senile, senile, and vascular dementia. Try to review the most important aspect, that is the modifiable and the non-modifiable risk factors for this particular entity. I would like to highlight the recent evidence which we have for the dementia prevention, which is the focus of this talk, and how it can affect our clinical day-to-day clinical practice. Now, as we all know, that dementia is already and will be the greatest global health and social challenge of the 21st century. Why it is so? Because more than 55 million people have already dementia worldwide. And this is almost 5% of the world elderly population, that is more than 60 years of age. And what is more striking is that more than 60% of these are living in the low and middle income countries like India. Alarming point is that 10 million new cases are added to this current population every year. And the total number are projected to reach 82 million by 2030 and to cross 150 million by 2050. Many patchy epidemiological studies about the prevalence of dementia in the elderly population from India and various parts of India have shown a very, I would say, alarming prevalence rates to the tune of 3.39 to in northern India to 1.25 in the people with more than 65 years of age using various criteria, although it is very patchy. And the most important aspect to understand is with our population, national population also aging, and if the age-specific population prevalence of the dementia doesn't change over the period of time, as per the Dementia India report, by 2050 we are going to have beyond 14 million people being affected by dementia, which is almost more than double which we have currently in the 2025. We in Haryana are sitting at the above average percentage of the elderly population as shown by this graph. So we are going to face this current challenge. And why this is important? Because this is definitively a medical challenge, but it's an economic burden on the globally for the government, for the communities, for the families, and definitely at the individual level also, because of the loss of productivity. And its global cost annually is to the tune of 1,818 billion US dollars. And what is more important is that 85% of this cost is basically due to indirect, that is family and social, versus due to medical care involved in these people, care of people with dementia. And there is a big gap, especially when it comes to a country like us, where the health systems are still ill-equipped and under-resourced to cater to the need of people with dementia. And with our society aging and increasing in the dementia prevalence, it is going to be a major health service implication for the care of such people and the support of caregivers, which is an equally important aspect of this particular disorder. Because most of the people who are dementic, they are having lack of insight into their own problem, and the caregiver burden is an equally important aspect which we as clinicians have to address. Now, talking about dementia, which is more aptly called now as a major neurocognitive disorder as per the DSM-5, is a group of disorder which is characterized by a decline from a previously attained cognitive level. That is, it represents a definitive change from a patient's prior level of cognitive ability and is persistent and progressive over time and affects the activities of daily living and social functioning. What is very important is the diagnosis of dementia cannot be made in a setting of an acute episode of delirium. Although I would like to highlight that people with dementia are at increased risk of having an acute confusional state because of their decreased brain reserve or delirium. They are more prone to delirium. So here we keep a possibility of dementia, and once they present with delirium to us, we call them as having beclouded dementia. Now, another important aspect which is to be highlighted here is that memory is the most common, but is not the only cognitive domain which is involved in the or affected in the dementia. There are other domains to cognitive domains also, which include executive dysfunction, like performing day-to-day and planning for a day-to-day activity, complex attention, that is like multitasking, language, perceptual motor, that is visual spatial orientation, and there is a social interaction. Sometimes the behavior also changes. So we have to keep all of these cognitive modalities and domains in mind while we assess the people. It is not the memory which is only to be assessed and evaluated either using history or clinical examination. Another important aspect is that if someone reports cognitive decline, either subjectively or a caregiver brings a person to you with a reported cognitive issues, then and it is definitely found not to be normal for any that particular age, but is not affecting the functionality of that person. Because if you remember from this slide, that it has to, dementia per se by definition has to affect the activity of daily living and the social functioning, whereas if it is not affecting the normal functional activity, we call it as mild cognitive impairment. Now this aspect is equally important because there are certain modalities, certain interventions which can be performed at this level also to prevent the further deterioration or the progress to what is called as the frank dementia. Because there is, for the, at least for the Alzheimer's, there is a 12% annual conversion rate from an amnestic variant, where the memory is the modality which is affected as the domain in the mild cognitive impairment. And there is a 12% annual conversion rate to a frank dementia. Now, another important aspect, as I have already mentioned, is the delirium. So someone who presents with a rapid acute onset, fluctuating course of inattention or altered consciousness, but with a disorganized thinking, please think of delirium first. And you can have both the variants, either fluctuating, that the person can be agitated, where we call it as a hyperactive variant of delirium, or they can just having a hypoactive or a, so they can become more dull, they can become psychomotive, less responsive. But what is more important is that it is an acute confusional state, or at the max subacute, progressing or setting in between days to weeks, as compared to dementia, which usually progressive and is insidious in onset from and progresses over months to years. Now, the consciousness level is usually affected in delirium, but it is not affected in dementia. The sleep-wake cycle, you will have a sleep-wake cycle disrupted, that the patients are awake in the night and they are sleepy during the daytime. It can be seen with advanced dementia, but in early on cases from the onset, this is not usually a case with dementia. Now, coming to what is pre-senile and what is senile. So any dementic illness which qualifies for the definition which we have just discussed is the onset is before the age of 65, we call it as pre-senile. If it happens beyond the age of 65, we call it as senile. Why this dichotomy is important is because of the possible causes, like the degenerative dementias, particularly the Alzheimer's type of dementia, which is the most common type of dementia with the elderly population. And age is the biggest risk factor, as I have highlighted in the first slide only, is the most common type of dementia with the senile dementia, that is people beyond the age of 65. And with every moving decade, there is a steep increase in the prevalence of Alzheimer's dementia. The most second common type of dementia is the vascular dementia, which is again one of the topics for today. And if we assess these people, the dichotomy between people, especially beyond the 80 years of age, close to 80, the dichotomy is decreasing. That people who will have MRI representation or of chronic cerebrovascular changes on the MRI, we will find histopathological changes like tau pathology or amyloid plaques in the histopathology samples, or there will be a temporal or a hippocampal atrophy in people who have MRI changes suggestive of vascular dementia. So these are the people where we will have a mixed picture. And now, because this dichotomy is getting diluted, most common dementia entity is a combination of Alzheimer's disease and vascular dementia pathology, which is seen in 80% of the cases in senile dementia. When we talk of pre-senile, I'll be coming to the reversible or the secondary causes of dementia. But for the neurodegenerative part, the most important type of dementia which we have to remember is the frontotemporal degeneration. Why it is important? Because early onset Alzheimer's is less common as compared to this entity, which is frontotemporal degeneration, where you will have a family history, behavior changes will predominate, and maybe the presenting symptom as compared to the Alzheimer's, where memory or visuospatial disorientation is more common. Another important aspect is that there could be a mix of etiologies. So as for the Alzheimer's and vascular dementia complex, we have discussed, there could be a mixture of neurodegenerative and there could be superadded secondary causes also. So if you are seeing a person with predominantly a degenerative dementia, you should still think of some other reversible causes also. But for the pre-senile onset, the most important, which I have already highlighted, is the early onset Alzheimer's, which is less common as compared to the frontotemporal dementias. Another is the Huntington's type of this is the type of subcortical dementia. More importantly, and more prevalent is the dementia due to head injuries. And why I'm highlighting this fact is this is preventable. Road traffic accidents are preventable, and occupational accidents, we are sitting in a state which has got a lot of industry. We do get a lot of patients who uh, they are prone to injuries, and due to concussion, contusion, or even the elderly population can have trivial trauma leading to subdural hematoma. They can have CSF leaks leading to intracranial hypotension, which can lead to cognitive impairment. So these are all preventable causes of pre-senile dementia. Another preventable or treatable causes of pre-senile dementia are the infections. Now, this particular MRI photographs, which just appeared on the left half of the screen, is from the HIV infection. Now, we all know HIV is a preventable disorder, and the cognitive impairment is preventable. How? With the use of highly effective antiretroviral therapy. And this cannot be overemphasized that the cognitive impairment seen in HIV patients can be reversed with the effective use of heart and early introduction of heart therapies. Same goes with the detection of cases of limbic encephalitis, which is an inflammatory disorder of the brain. Same goes for multiple sclerosis, with young population getting affected with this chronic inflammatory brain disorder. The neurocognitive decline can be uh, diminished with the effective control of inflammation of the brain. Same with in immunocompromised hosts like HIV or post-transplant recipients, we do come to see cryptococcal meningitis as an opportunistic infections, but more and more we also are seeing people with cryptococcal meningitis leading to cognitive symptoms, decline symptoms due to hydrocephalus or chronic meningitis. Now, these are the treatable causes of or preventable causes of pre-senile dementia. Coming to the vascular dementia, this is one aspect where I think most of the modifiable risk factors play a role. Now, what is understood of vascular dementia is that a lot of white matter changes on the brain MRI will lead to cognitive decline. That is not important. Someone who just gets a posterior cerebral artery stroke, like on in this first MRI, because of the involvement of the mesial temporal lobe, or a strategic infarct like a thalamic stroke, can also present with cognitive decline or cognitive impairment. Now, obviously, with lot of multi-infarct state acquired in a stepwise fashion, some people can show a steady decline in their cognitive functions. Now, with the widespread white matter involvement, which is called as the Binswanger disease, cognitive decline is quite obvious, and the MRIs can be suggestive of vascular dementia. But what is most highlighting is that in addition to the neurocognition part, the vascular dementias are completely preventable because there are a lot of modifiable risk factors which we are going to talk about. They are preventable and they can change the course of the disease from the normal cognition or at the level of mild cognitive impairment also. So when we talk about dementias, first dichotomy which we made was the from the age of onset, that is the pre-senile, and the senile, that is less than 65 or more than 65. The next dichotomy we made was from the degenerative causes and the secondary causes. The third dichotomy is from the reversible and the irreversible. The categorization is from reversible and irreversible dementias. Now, 19% of the dementia or the cognitive impairment is potentially reversible, and 23% of the cases you will find even in the degenerative dementias, they can have concomitant reversible conditions. So it is worth looking for any nutritional deficiencies like predominantly B12 deficiencies, any toxics, especially the medications. Now, tricyclic antidepressants, which are very commonly prescribed, many of other sedative drugs, they can decrease your cognitive potential. So these have to be kept in mind. Metabolic factors like hypothyroidism, they have to be kept in mind. Inflammatory disorders like paraneoplastic and limbic encephalitis, I have already told. With the use of proper anti-inflammatory therapy in the form of methylprednisolone pulse therapies and neuromodulation therapies, these neurocognitive impairment is potentially reversible. So there are basic principles. Think of reversible conditions causing memory and cognitive impairment, even in degenerative dementias. Try to determine that there is definitive true cognitive impairment and not a false cognitive impairment just because of the current in the setting of which can happen, which we call and we all know as pseudo dementia, which is seen in people which are severely depressed. We have to check that what all domains other than memory are involved, and then work uh, through an approach manner towards the etiology of the particular dementic illness. So we have at our disposal history and mental status examination, the tools which have been there for a very long time since inception of the medical sciences, and these are the particular domains which we need to study. How we usually look at this, and people in their just OPDs can look at, is simple learning of these tools which are 10-minute, take 10 minutes, and you can train your staff also to administer these tools which are available on internet. This is first tool is the MMSE, but the only challenge with this is that is the mini mental status examination is that it is insensitive to mild dementia. The good part is it has simple 11 basic questions, and it can be administered in less than 10 minutes time. Very easy to practice and learn and to administer. You can administer this to a fifth grade pass person, and we have an age normative data available. Usually cutoff is the 27 with the total score of 30, that you take it as cognitive and you can probe it further. So you can find people in the population who are at risk or are having cognitive impairment. Now, the clarifying about the mild cognitive impairment, that if someone reports to you with cognitive impairment, has um, shows low scores on mini mental status examination, but the activities of daily living are not affected, they will have a mild cognitive impairment. So there is a tool which is looks at mild dementia also. This is called as the MOCA, or the Montreal Cognitive Assessment Battery. This is a similar type of tool. The biggest advantages of these tools are they are available in indigenous languages also. They are available and they are validated in Hindi languages. So what we usually use in our day-to-day clinical practice is both English and Hindi questionnaires. Why they are important? They give you a construct, they give you a probable etiological diagnosis, and if you find that there is a degenerative dementia from the age of onset, from the pattern of progression, and try to find modifiable risk factors, which by 2022 in this landmark paper in 2020, lot of modifiable risk factors have been highlighted, like the level of education, which if it is less, hearing loss is present, traumatic brain injury history is there, and you have the modifiable risk factors like hypertension, high alcohol use, obesity, smoking, physical inactivity, diabetes, you run a risk of dementia in future. Although individually these risk factors run a very low risk, but collectively they attribute and they can contribute to the cognitive decline to a high level. Using these modifiable risk factors, there was a very important publication which was published from WHO, where they published guidelines for risk reduction of cognitive decline in dementia in normal population or in people who have been diagnosed with mild cognitive impairment. So I will, based upon this particular publication, I would like to highlight the important recommendations and the basis for that and what they have recommended. The most important intervention which they have recommended is the use of physical and to increase the physical activity, both for people who have a normal cognition or have mild cognitive impairment. What is recommended is aerobic activity, which should be in the bout of at least 10 minutes and should be there for 150 minutes per week, moderate level of exercise, because it reduces the risk of cognitive decline by 28 to 35% due to neurogenesis, blood flow, and elevation of mood. For people who have poor mobility already, they have recommended muscle strengthening activities and physical activities which can enhance their balance and prevent falls. And I have already highlighted falls can lead to head trauma and either result in subdural hematoma, or it can lead to concussion injuries. Now, this type of muscle strengthening activities in people with poor mobility should be happening on 3 or more days per week. Still, for people who can, with advancing age, if they are not able to perform, you will get patients who will say that we are not able to walk. How should we uh, engage in the recommended exercise? So, what is the recommendation for those people is that they should be physically active as far as walking, as far as possible. So, simple walking in the house is sufficient enough. Another important is the cessation of quitting tobacco use is not only it reduces the risk of cognitive decline and dementia incidence, but it has got a lot of other health benefits. And there is no other way we can go for counseling. And what works the best is the counseling by the treating physician. So if you just ask the person to quit, it helps the most. Although there are certain pharmacological ways of quitting, like nicotine and vanillin, but they are not recommended because they have their own set of side effects. So what is the most important is strong recommendation and counseling, or an advice from the treating physician. Then comes the nutritional intervention. There, it cannot be overemphasized that the diets which are rich on fiber, low on carbs, low on fats, and constitute the Mediterranean. So what was found is a strict adherence to these Mediterranean diets, or the DASH diets, which we all know have been recommended for hypertension. They have been found to have lower cognitive decline, and they indirectly help with your cognitive health through obesity, managing the obesity, hypertension, and diabetes. So what is recommended is the healthy, balanced diet is what constitutes that is 5 portions of fruits and vegetables a day, less than 10% of your total energy intake coming from refined sugars, less than 30% coming from fats, and less than 10% coming from saturated fats, and less than 5 gram of salt intake. So this is something in addition to what is most commonly asked is the about the supplementation. So till now, isolated vitamin B or E or PUFA, or that is omega fatty acids supplementation, is not recommended for prevention of the cognitive decline or dementia onset. Now, the most important thing is that vitamin E is something which can accumulate and can cause toxicity also. Another important intervention is to definitely reduce or cease hazardous or harmful drinking. Now, because of a ever discussed U-shaped relation of the alcohol with the cardiovascular risk factors, that it is low level of consumption of alcohol in the, especially in the form of red wine, has been helpful. It's a big question mark these days, and the usually permissible limit of 21 units of alcohol per week is something which should not be recommended by the treating physician or the consulting clinician. There are other disorders which can directly or indirectly cause cognitive impairment, and definitely alcohol leads to lot of injuries. So again, indirectly they can be contributing to the cognitive impairment. Weight management through balanced diet, use of low glycemic index foods, reducing the sedentary behavior, regular engagement in daily physical activity, because of the improvement in the metabolic factors like glucose tolerance, improving the insulin sensitivity, lowering the blood pressures, lowering the oxidative stress and brain inflammation. This intervention is very important, especially for the midlife, that is from the age of 45 years to 65. Weight management works the best, and it is strongly recommended. Now, control of hypertension cannot be overemphasized, but there are few caveats to this, that the hypertension, especially in the early or the midlife, there is a definitive increased risk with the late life dementia. It has to be managed as per the recommended guidelines for the normal population. The same drugs like angiotensin convertase enzyme inhibitors, ACE inhibitors, ARBs, or calcium channel blockers are to be used. But what has to be taken into consideration, especially for the elderly population, is to look for specific contraindications, like thiazide diuretics can cause hyponatremia. There can be the especially the Prazopressin or the alpha blockers can cause orthostatic hypotension. They can result in falls. The strict control should never be targeted or an urgent unless there is a medical urgency or emergency. We should not be leading to abrupt control of blood pressures, which can again further cause further clinical decline. Uh, Same goes for diabetes. The risk of hypoglycemia is something which has to be always discussed with the person. And the control of diabetes, not only with the help of medication, but also with the lifestyle interventions, it helps directly with the cognition. But the complications which are associated with diabetes or long-standing diabetes, like nephropathy and reduced vision due to retinopathy or hearing impairment, can increase the risk of dementia. Dyslipidemia, the most commonly studied drug is simvastatin, but its use for people to prevent dementia is discouraged. The midlife dyslipidemia should always be treated, possibly with the dietary modifications, and with the statins have to be used if definitely there is a increased cardiovascular risk factors other than dyslipidemia, like diabetes or hypertension or a history of stroke or coronary artery disease. The depression needs to be addressed because presence of even early or midlife depression, and especially the late onset depression, doubles the risk of dementia. Although the interventions should be non-pharmacological predominantly, antidepressants use are discouraged. Hearing loss should be screened and should be addressed, but hearing aids for preventing dementia are discouraged. The most important intervention is the cognitive stimulation therapy. That means engaging the people at risk having mild cognitive impairment or normal cognition and recommending them to participate in activities which stimulate the brains like Sudoku or mental arithmetic uh, are recommended. And people who have mild cognitive impairment should also be engaging in structured, planned, and from professional cognitive training. They should be getting unassisted these types of training to improve the brain function and brain resilience. Engaging in social activities, something which our culture should be proud about, but COVID has put a great challenge to this. And what Pavan Goyal sir highlighted, that because of our increased engagement with just social media, we are now moving towards low social engagement, and this is something which definitely causes cognitive decline, and could be because of the disease process itself. That patient gets withdrawn, they don't want to talk, and they feel embarrassed because they cannot interact to that level. So social participation, social support from the caregivers, from friends, family, extended family, is something which is needed throughout the life course of a person, and is something which is strongly recommended. So what we understood is, even for neurodegenerative dementia, the path, the natural history curve can be changed if we address the modifiable risk factors for the vascular damage. We intervene to increase the brain resilience. We control the neuroinflammation and oxidative stress, which can be indirectly because of the many of the medical conditions like obesity and diabetes, and in the lack of drugs which have failed the trials which were used for degenerative dementias to control at even the preclinical stage to address the amyloid plaques. We have what
I
we have.
think, Dr. Manish, just a minute. Dr.
Yeah.
Neelam, your screen has been shared, I think. So please, you see to it and please
Has
uh,
been changed. Yeah.
stop it.
Is my screen visible, sir, now?
No,
No,
no.
no, your screen is not visible. Dr. Neelam Best screen was visible.
Mhm.
I think there are two screens which are visible. Now your screen is
Now
visible.
it's fine.
Okay, sir.
And
Yeah.
okay,
I'm just going to wrap, sir, in another 2 minutes.
please.
Yeah. So, as we have discussed, that neurodegeneration, along with that, brain resilience and vascular damage due to a lot of modifiable risk factors, and control of neuroinflammation, oxidative stress also helps, and lack of treatment modalities affecting the or changing the natural curve of the degenerative dementias. We have at our disposal the prevention strategies, either targeting the body to protect the brain, like addressing the and preventing the cardiovascular morbidity, or intervening through the compensatory mechanism to counteract the brain aging through education, or engaging in cognitively and socially stimulating activities, or we have something which can increase the lifespan in a healthy way, like the physically active lifestyle, smoking cessation, and consuming healthy and balanced diet. Now, what till now we have understood is that in isolation, only modest benefit can be acquired if we focus on these modifiable risk factors in isolation. So, what is recommended and has been now shown through randomized control trial is this construct, which I just wanted to highlight to this august audience, is that as the life advances, there are different type of set of interventions depending upon the different type of risk factors which prevail during the lifetime, especially the hearing loss, hypertension, and obesity, having the maximum impact if intervened in the middle life and in the late life. Even at that point, if someone leaves smoking, their depression is addressed, they still engage in physical activity, their prevent social isolation from happening, there is a strict control of diabetes. Even in the presence of genetic risk factors like ApoE4 allele, they can reduce the chances of cognitive decline. Now, this has been documented in a very well conducted finger trial. And what this point particular, why I am mentioning this trial is because this was a global study, had India also as part of it, and it showed that early is better and multimodality is definitely better. That you should have healthy food, engage in physical activity, have continuous mental stimulation, engage in social activities, and address your cardiovascular risk factors. And this is the level of impact it showed on overall cognition to the tune of 25%, and executive function was improved by 83%. Now, this is being further refined by more intensive, being studied by use of intensive training, one-to-one training, vis-a-vis usual care. Now, so to conclude, what is most important is that cognitive impairment in dementia are multifactorial. They are not one single entity with potential modifiable risk factors, even in neurodegenerative dementias. So you should be screening all the midlife population for any potentially modifiable risk factor. Multidisciplinary, multi-domain, life course, intensive preventive approach may be effective in changing the natural path of the mild or cognitive impairment. And early intervention works the best. There is a need to integrate the dementia prevention in the chronic disease care, which we all are offering. We all have to play a key role in the implementation of these strategic interventions. And then there is a definitive need, like these meetings, for creating a public and clinician awareness and to bridge that gap. What is futuristic is to develop effective and sustainable interventions for different geographic, economic, and cultural settings. With that, I would conclude and wish us all graceful aging. Thank you for patient listening.
Thank you, Dr. Manish. It was a wonderful talk, and you summarized all the aspects of dementia so nicely. One or two small requests that you have put so many things. Definitely, those are very good. But if we can just have a small chart or something for the risk factors and for the this thing early diagnosis, like you gave one slide regarding what has to be done. If it
Right,
can
sir.
be structured and if it can be passed on to all the members,
I'll do that, sir.
probably not only our patient, family, and the society will be benefited, but I think our own fraternity will also be benefited.
I'll do that, sir.
The risk factor
Because
have mentioned smoking and this thing, alcohol, diabetes. Definitely, we have to keep all these things under check so that we can have a graceful aging. And it was a wonderful session, definitely very eye opener and very illustrative and very educative also. Thank you, Dr. Manish. Thank you,
Thank you,
students.
sir.
If anybody has any question or any comment, please unmute and ask directly.
I think Dr.
Good,
Neelam.
Good evening, Dr. Malik here, Dr. Pramila Malik. Excellent presentation, Dr. Manish. I just wanted to ask that this in Alzheimer's majority, there are amyloid deposits in the brain.
Yeah, ma'am.
So any lifestyle modifications to reduce that so that we can reduce that, any modification in the diet or anything? What is the basic cause of that amyloid deposit? This
Ma'am, it's
Alzheimer's is
the actually misfolded protein and something which we one protein leading to another cascade. It's a cascade.
why
So
it
once
happens.
starts- Yeah. So there are some unidentified genetic factors,
Okay.
and one of them I have already highlighted, ApoE4
Yeah.
epsilon 4 allele. If we harbor that gene, but there is still no such recommendation to find out that every population has to be screened for that allele. Now, what
Okay.
is more important is that I highlighted the fact that more and more vascular dementia pathology is also being found in people with Alzheimer's. So there
Okay.
comes the role for risk reduction of the modifiable risk factors. So people who have Alzheimer's, we should be looking for reversible factors like B12 deficiencies, associated hypothyroidism, or they should be engaging in physical activity, because these people will have and engaging in cognitively active cognitive exercises, like I gave example of Sudoku, crosswords. Depending upon the educational level, I give mental simple arithmetics also to be done by the patients who have already developed Alzheimer's, because what you can at the max once they have developed dementia is to change the curve, that is the rate of decline. You can just change the slope curve, steepness of that curve. So that is something which you can do, and you can plan for these patients.
Besides these modifiable factors like hypertension, diabetes, hypothyroid, and smoking cessation, any other changes in the diet? Any studies to
No,
prevent
ma'am.
this
No
amyloid
studies as
deposition?
of now have.
Any particular diet leads to excessive amyloid deposition or no?
No, ma'am. Nothing.
Nothing of that.
There is no such particular diet which can prevent or which accelerates this type of
And
deposition.
is the screening for this gene available in the this thing?
Ma'am, it is not recommended.
It is not recommended, but
It
is
is
it
not
available? Can
It
it
is
be
available,
tested?
ma'am. It is
It can be
available.
tested.
Yeah, it
Okay.
can be tested, but there is no need. We usually do it for people we do for early onset, where typically there is a family history, first of all, very
Okay.
early onset or young onset Alzheimer's dementia. Then case to case basis, a decision can be made for such testing.
And how is that? How much is the treatment helpful in once the Alzheimer's has set in?
Yeah, very
How-
good
how
question, ma'am.
much
I
we
didn't
can-
touch upon that because that was out of the scope
So
of
just
this
I'm asking
discussion.
how much you
Yeah.
can procrastinate.
No, ma'am.
is
So,
tested.
as far as the pharmacological treatment for Alzheimer's is concerned, it is only helpful up to the moderate level. That means from mild stage to the moderate stage. When the advanced dementia sets in, then when the patient is totally dependent for his day activities or daily living on the caregivers, then none of the medications usually helps. There are two set of medication which are usually used. One is the this is the acetylcholine esterase inhibitors like donepezil or rivastigmine. The other one is the NMDA receptor agonists, which are the mementins. So these are the something which are used.
With
So
the treatment if we start the treatment in mild to moderate,
yeah,
can the progress
they
be
are
halted?
modest, they moderately or marginally help them.
And the progress can be halted, or it
No,
will
ma'am.
progress?
No.
Won't.
Unfortunately, nothing can halt the progress. That's the unfortunate part of it. So they are
Thank you so much.
symptomatic treatment at the best, and they help only with the early and the mid or the moderate level of the disease, not with the advanced disease.
Thank you.
Any other question?
Yeah, Dr. Neelam had one.
Yeah.
Okay.
Good evening, Dr. Manish.
Yeah, ma'am.
I apologize for my screen being shared in the middle of the meeting and
No problem, ma'am.
disturbing you. So I have a couple of questions. Number one, I saw a slide about the risk of pollution
Yeah,
related
ma'am.
to dementia. Can you please elaborate on that?
Yeah, ma'am. Ma'am, there are two types of pollution which we talk about. One is the indoor pollution. The other one is the outdoor pollution. Outdoor pollution predominantly in the yesteryears was because of the use of lead containing gasoline. So the vehicular emissions which were coming were high on content of, and there were number of studies which have even highlighted the fact that these were responsible for the lead poisonings in kids even, and even school going kids were showing cognitive decline due to that use, and that led to a major public health decision to eliminate lead from the gasoline. So this is something one which is there. The Another important aspect is the indoor pollution coming from the passive smoking, or from the currently, ma'am, we are inhaling a lot of low oxygen content. So this puts a unnecessary strain on the cardiovascular system. We know that diminished oxygenation, either due to pollution or inhalation of decreased oxygen concentration, can put raise blood pressures. They can raise your insulin resistance as well. So this is something which is of paramount importance, to the point that there has been a commemoration of a World Brain Day dedicated to uh, the addressing the pollution, only air pollution. So there was one full year that campaigns were held pan world about the pollution also. So indoor pollution, lot many other factors also play, but predominantly it is the passive smoking, air. Again, the paints were containing lead. So all these heavy metals, they affect your cognition.
Okay, thank you. And my other question is regarding the routine screening for cognitive impairment in outpatients.
Yeah.
Who are undergoing a kind of a preventive check. Do you think introduction of routine screening would help in, I mean, it should be recommended, or it would help in further assessment and management and possibly prevention of dementia?
A very good question. And I think that was the crux of the talk. The current evidence says that these interventions, when done in isolation or done for population at large, they will not be so much impactful. They will be impactful when they are done early on people who are at risk. So that who are at risk: one, who have a family history of dementia; second, who have presence of one or more modifiable risk factors; third, who are having at present mild cognitive impairment, because I told you there is an annual conversion of those set of people who have mild cognitive impairment to frank dementia. So these interventions matter the most for people who have MCI or have risk factors for that cognitive impairment. So screening tools, the one which actually we use is MOCA, but unfortunately that has been made paid. So still for routine clinical practice, you can download it. It is freely available on internet. Both Hindi as well as multiple English versions are available, because people at times, when you reassess them after a gap, they tend to learn the things, or place out try to play outsmart you, that they have know what you are going to do the next. So the scores can be deceiving. So for them, you have different versions available. Another thing which I would like to highlight here is a simplest test, because all of them are time consuming. They take at least 10 minutes of your clinical time. One single test, if I say, out of all this battery, which we use, is a serial 7 subtraction test. It's 100 minus 7. You ask the person कि एक सिंपल भाषा में बोलना है, अगर 100 में से 7 घटाए तो कितना होता है? The first answer you will get is 93 or 93. ठीक है? But the catch is that you will तो उसमें से 7 घटाए तो कितने होंगे? That means 7 minus from that. You are not supposed to tell that person the previous number. So this particular test is a test for attention. That means he was attentive for the command that he has to subtract 7 from 100. Then for short-term memory, because he remembers the last figure he has calculated. This is a test for calculation. So different areas of the brain, because first aspect of any cognitive function is attention. If person is inattentive, you can't screen that person. I didn't go into that depth, but if one test you are supposed to perform is 100 minus 7, that is serial 7 test. Ask the person and you have to do it till 5 correct answers. And they have a time bound. People can give you correct answers, but they will give it slowly. So there you will get an idea how fast they are processing. If they are taking time, but getting the correct answer, that means the processing is slow. So that indicates more towards subcortical dementia than cortical dementias. But the calculations, they can, and I have seen people who have been very good, like bank employees, cashiers, failing on these 100 minus 7. So this is something. What is 7 minus 100? 100 minus 7. 7 subtracted from that. 7 subtracted from that. So 93. They should say 86. Then 79. Then 72. 65. And it should be 1 second per answer. That is the speed which they should be calculating. So this is something the easiest you can do to pick up.
And I have one last question.
Please, ma'am.
Any limit for the BP reduction or BP control, which has been shown to be best associated, with the least chance of developing
So I think,
cognitive impairment?
yeah, that's a very valid question. And I think most of us there is a target. That is the reason I put the recommendation as that the target blood pressures are the same for people who have normal cognition or mild cognitive impairment. With a catch, if the patient reports you any symptom of orthostatic hypotension, that means they feel orthostatically when they stand up, they feel dizzy, or they have a blackout in front of them, or they sweat, or they develop tachycardia or palpitations. They have a frank syncopal attack. So all of these, if they are happening, that means you are over treating such patients. Second, what the simplest recommendation is to monitor it at home, because the blood pressure you will be finding in office settings, in a clinic settings, are usually more than what they get at home. And we tend to treat it as per our readings on the OPD paper. So we can maybe over treating these. So emphasize on monitoring at home, bringing those charts with them, seeing the trends throughout the day, timing of the medication, what type of medication suits them the best, addressing comorbidities, looking for particular drug specific contraindications, as I told. So these have to be catered. Target blood pressures for the usual population without diabetes is less than 130/80. And for diabetic, it is less than 120/80. If Dr. Goel sir has to correct me if I'm wrong.
Perfect.
Yeah. So this is something which is the usual norm for everyone. But any blood pressure where they become symptomatic for hypotension, we have to stop treating, over treating or titrate the drugs.
Thank you so much.
As you have already
Excellent
mentioned that thiazide diuretics,
Yes,
they are
sir.
cause of significant hyponatremia, particularly in elderly patients in temperate climates.
Yes, sir.
And that is definitely adding to our number of dementia patients.
At least, sir, these patients will be landing up with dementic patients will be landing up with delirium very commonly because they have a low brain reserve. And as you rightly mentioned, during this season, because they replace the loss of salt and water with only water during the summer season. So the loss of sodium is again compounded by the fact that it becomes a dilutional hyponatremia also.
Yes.
They do polydipsia, they do plain water intake, which again compounds the problem.
Thank you. Thank you very much, Dr. Manish. Excellent presentation.
Dr. Manish,
Thank you.
one question from my side. Because of increase in modern lifestyle, role of multitasking, sleep deprivation, overuse of electronic gadgets, and engagement with social media. How much does this add to dementia in our patients?
Sir, I think this is again a multi-factorial and implication of this on our cognitive health, I would say, because indirectly it leads to sedentary lifestyle, because we are stuck to our, instead of participating in any type of uh, physical activity, we tend to consider this as a leisure time, spending more time on gadgets and social media. Second, the social interaction which I talked about is diminishing. Third, it has got a challenge of passive learning, sir. We were seeking information earlier by meeting people, by scrolling books, or by reading books. Now, even with the AI, you put a query, it gives you the passive answer. So there is no engagement or no further planning. Executive functions are reducing. We need not plan anything. I could have prepared this presentation by putting in the keywords in the chat GPT, but it is not the case. I have to, the other way around is, I have read articles, I have I have seeked that information from proper resources, and then, so passive learning versus active learning. At the same time, I can say that, yes, this technology can be used to good use also. Now, it was sheer wastage of paper if we ask someone to go for Sudoku books and everything. Now, what I tell them is that ask them to do the Sudoku crossword on digital media only. Or there are retraining learning exercises. You can ask people to mix and match. They can have difficulty in doing mixes and matches, like matching the word with the particular figure. So all of this can be used. Keeping record of these patients serially, we used to lose this record. So now we are serially keeping them and we can make a graph out of it. So all of this are the flip side of the technology. But as you rightly mentioned, these passive learning, sedentary lifestyle, and there is a binge eating while you watch long this engage in long I would say series and everything. So that again causes challenge. Another important, sir, preventable cause, which I didn't mention because of want of time in the presentation, was obstructive sleep apnea, which is something which is very important and is really underdiagnosed. And so that is something which we need to address. And again, weight management is something which helps for
Most
management.
important cause of OSA is obesity.
Yes, one of the biggest risk factors is obesity, especially the obstructive sleep apnea.
Any other question from any other participant? If there are no other questions, then
Sir,
Mira,
I could see few in the chat box, sir.
yes, sir.
I think
I have a question, sir.
yeah. Is COVID or its vaccine is responsible for post-COVID forgetfulness
Yes,
or dementia?
yes, sir. This is my question, sir.
Okay, ma'am.
Hello. Sorry, sir. I think there was a internet glitch. Yeah.
Sir, the question is COVID or its vaccine is responsible for post-COVID forgetfulness or dementia?
Yeah, I think very aptly asked. Uh, I have two articles, one in Financial Express and one was with the other newspaper, where two things were mentioned. One was the lifestyle modifications, the forgotten key to neurological disorders, management of neurological disorders. So this is one article which I'll share the link with Pawan sir, and then they can circulate it. The second one was that even mild COVID, this I wrote in January 2021, and now people call it as long COVID. Now, even people who were asymptomatic for COVID or had a mild COVID, they definitely showed some or the other neurocognitive impairment. There was decreased working memory, decrease in the executive functions, especially the I told you about multitasking. So that got diminished. And definitely there was impact on there has been increase through the cardiovascular risk factors, because COVID time saw high incidence of strokes and other cardiac events also. So because of that, indirectly also, there was a definitely rise in the younger population, or what we have discussed as pre-senile dementia.
Yes,
Vaccination, I don't have any data to suggest or to conclusively prove, but I think the mortality benefit which we got out of vaccination outweighs any risk, if so ever, is there for the COVID vaccine.
Gee, what I think, actually, I think the same. But I have experienced myself forgetfulness after the COVID. तो
This is
मुझे
a
अभी समझ नहीं आ रहा
problem.
मैं क्या करूँ जो आपने symptoms बताए वो I'm feeling the same.
Ma'am, this is something which is
vascular part of it, and neuronal degeneration because of viral overload. Probably they were the two causes which were enumerated in long COVID-related dementia.
Yeah.
Dr.
Actually, I
Manish
was
Mahajan.
I was diagnosed negative for the COVID vaccine. Every time I got the test done, but I don't know. That is why I asked if it's the vaccination
I told you,
Covishield.
ma'am. So
Yeah.
that was a very common problem, and I highlighted in the fact, and one of the articles I have also mentioned. So not only this, ma'am, anxiety, other issues which are behavioral, they were also much more common with people who had just mild COVID or
Okay.
asymptomatic COVID.
Please share the article, sir.
Ma'am, I'll do that with Pavan sir.
Yes, yes, sir. Thank you. Thank you.
Good evening, sir. Can I ask one question?
Yeah, please.
So, Dr. Manish, what role do you think psychologists can play in maybe in assessment and in some of the behavioral or cognitive interventions?
Yeah. So I think if we talk about psychology and keep away the pseudo dementia due to depression outside the domain of discussion, the most important is the psychologists who have been trained first in the neurocognitive assessments. That means they are trained to administer the various types of, because the screening tools which I have shown you are for the general physicians and the neurologists for the OPD settings. Now, once we see that, or we suspect that there is because these screening tools are not 100% foolproof, we can still miss on people who have dementia. But because I showed you MMSE is an insensitive tool for mild dementia. So when we suspect them, the clinical psychologist who is trained, they can do further detailed lobar functioning and can come up with the predominant domain. I showed you a slide showing all the domains which have to be assessed in detail, and then localization of that dementia, and then the etiological workup starts, that what could be the possible etiologies of involvement of either a frontal predominant or a temporal predominant or a parieto-occipital area involvement. So all of this is the first step, is the diagnosis. Second is the neurocognitive rehab. One is the addressing the modifiable risk factors by the treating clinician. The second is the rehab. Now, this rehab can happen after a stroke, because we all know about the physical rehabilitation which we offer to our patients with stroke, but there is a scope, and we are developing this at our clinic, is the neurocognitive rehabilitation. That means to enroll, and that is the reason in the concluding slide also I mentioned multidisciplinary approach. That means neurologist alone cannot perform these rehabilitation. He needs a good clinical neuropsychologist who can make a care plan, administer, and give you and assess the milestones which were likely to be achieved in a particular rehabilitation plan. So this is the biggest role which a clinical psychologist can do. Thank you, Dr.
Right.
for
Thank
asking
you.
this wonderful question.
Thank you.
Dr.
Thank you.
Dinesh Chabda is Professor of Psychology in Delhi University.
Sir,
Thank
glad to get this question from you, sir.
Sure. Thank you.
So even for such traumatic brain injuries, sir,
Mhm.
we get a lot of patients for rehabilitation where I was talking about, sir, if we talk about the gaps in the current practices and what can be offered, this is huge. And they are one CMEs in themselves. So the point is that here it was a message very loud and clear that even for degenerative dementias, don't forget the modifiable risk factors, the reversible factors. And because Dr. MP Jain sir asked me to emphasize on the salient points, so I'm emphasizing the key take-home message is that think about reversible causes, even in degenerative dementias. Think about modifiable risk factors, and that too from the midlife, not when you think that dementia will set in. So even childhood interventions like addressing childhood obesity, dietary control. I talked about Mediterranean diet. So the studies have very well established the effect only when it is strictly adhered to. It is not that it is a fashion type that you use that occasionally or sparingly. So this is the key home message.
Thank you, Dr. Manish. And